Good morning, everyone. Thank you for joining us for this interesting talk. Lynn Dietrich is a clinical educator with our Florida Caribbean AETC who has more than 30 years of healthcare experience, spending the last 13 years as a nurse, educator, researcher, and writer. Dr. Dietrich has developed and presented educational sessions for topics on HIV, has spoken at national conferences, and has authored 2 online educational modules targeted for hospital staff. In addition to her wealth of knowledge and her clinical education experience, Dr. Dietrich has published 25 peer-reviewed journal articles and holds a doctorate in applied medical anthropology from the University of South Florida. It's a great pleasure for me to introduce Dr. Dietrich, and please remember, if you have any questions for the speaker, to use the question and technical support issue box to the right of the screen. Type them in anytime during the presentation, and they will be answered at the end of the session. Dr. Dietrich, I'd like to turn this over to you.
Thank you, Dr. Beal. Good morning, everyone, and welcome to this most important session on HIV testing. Okay, we need to advance the slides. Okay, our session-specific objectives are here. I'll give you a moment to take a look at what those objectives are. Okay, and here's an outline of the way the session today is organized. Okay, let's begin. In part 1, we're going to talk about the impact HIV has on our country. As you probably know, HIV has reached epidemic proportions in our country. Almost 50% of Americans know someone living with AIDS. But even though HIV testing has become more acceptable, there is still stigma and fear surrounding the disease. And 1/4 of our U.S. infections are in our adolescent youth. HIV testing to identify those unaware of their infection is prevention. Okay, in 2011, you can see what the statistics for HIV were in the U.S. An estimated 1.2 million people are living with HIV and or AIDS. Approximately 1 in 6 do not know they are infected. Over half of all adults aged 18 to 64 have never been tested, and less than 1/3 of people at high risk for HIV infection have never been tested. And if you look at the statistics on this slide, you'll see that in 37 states, we've had almost 50,000 new cases, 79% which are male, and you can see the breakdown among the various racial groups. And the top 3 states reporting the highest number of cases are California, Florida, and Texas. We're going to just focus our discussion today on Florida and the Caribbean, but because Florida is in the top 3, it's really imperative that we step up our testing efforts here. Basic Florida statistics. HIV has an impact on Florida. We're 4th in the nation in total population, 2nd in the nation for new HIV cases, 3rd in the nation for new AIDS cases, and 2nd in the nation for cumulative pediatric AIDS cases. Those statistics are alarming, and we have to do something about it. The HIV epidemic in Florida, here you can see some more statistics. We're 2nd in the nation in newly diagnosed cases of HIV, 3rd in the nation in newly diagnosed AIDS cases, and pediatrics, the numbers are even more alarming. This shows the seriousness of our problem and why testing is crucial. I also want to show you the breakdown of how HIV affects our communities in Florida. So in 2011, blacks comprised only 15% of the adult population, but represented 55% of the AIDS cases and 48% of the HIV cases reported in 2009. Hispanics comprised 23% of Florida's adult population, and they account for 19% of the AIDS cases and 21% of the HIV cases. So you see, we really have a lot of work to do. Now this graphic shows us what the HIV infection rates are by county of residence reported in Florida for 2013. HIV testing is important all over Florida, but it's especially important in the areas in dark red, where HIV cases are the highest. Now these are by county of residence, and it's per actual number of cases. So the areas in the dark red are really where we need to focus our efforts. The statewide rate is 30.9 per 100,000 population, and it should be noted that these numbers exclude the Department of Corrections. And the numbers on the counties are the number of cases reported. So you can see there's areas where we clearly have a lot of work to do in terms of testing and identification. We also want to look at the Caribbean. HIV and AIDS in Puerto Rico is a problem, and within the overall Caribbean, HIV and AIDS infection rates are among the highest in the world, second only to those of sub-Saharan Africa. HIV is a serious problem in Puerto Rico, as you can see from this slide, so testing is crucial in order for patients to be identified and begin treatment. And here on the slide, you can see the AIDS rate for Puerto Rico is 15.7%. The HIV rate for Puerto Rico is 28.6%. And you can see that Puerto Rico ranks fourth in AIDS cases among all U.S. states and territories. For its population size, the rate of HIV in the U.S. Virgin Islands is extremely high. The rate is even higher than in Puerto Rico or Florida. Testing is important in order to identify new patients and get them into treatment. So now that we've got an overview of what the epidemic statistics are, we want to talk a little bit about the case for increased testing. The slides we just reviewed show us that it is imperative for routine HIV testing to take place in health venues across Florida, Puerto Rico, and the U.S. Virgin Islands as a means of stemming the epidemic of new HIV cases. Early diagnosis and treatment is key to getting the spread of HIV under control. Increased HIV testing rates are crucial, and in this section we're going to discuss some of the basic definitions of HIV testing. Okay, before we do that, I'd like to ask you all a question. I'd like you to respond with what type of facility you work at. And I encourage everyone to vote who's on the line. Okay, if you haven't voted, I'm going to end it. Okay, so now we're going to look at the results. You'll see from the results that most of our respondents work in hospitals and health departments. And those are really two of the frontline areas where we're really trying to increase our testing. Okay, our next question. Are you currently doing HIV testing at your facility? Please answer yes or no. Okay, so 100% of you answered yes. Boy, I'm impressed. That's wonderful. So now we are going to use you to be the Army to go out and help your colleagues understand how important it is to do the testing. Okay, now that we see that everybody on the line is testing, we still want to go over some routine definitions of testing so that we're all on the same page. Routine testing. HIV screening that is performed routinely during health care visits. That's different than diagnostic testing, which is used to test people with clinical signs or symptoms consistent with HIV infection. Screening is performing an HIV test for all persons in a defined population, whereas targeted testing is performing an HIV test for subpopulations of people at higher risk, typically defined on the basis of behavior, clinical, or demographic characteristics. Informed consent is the process of communication between the patient and provider in which the patient can make a well-informed decision about whether or not they want to undergo testing or whether they want to opt out. Opt-out screening means that you have to notify the patient that the test will be performed and that they have the option to decline or defer the testing. And their consent is inferred unless they say or write that they don't want to be tested. And HIV prevention counseling, that's an important process, and notice the word interactive. It's an interactive process of assessing risk, recognizing specific behaviors that increase the risk for acquiring or transmitting HIV, and developing a plan with the patient to take specific steps to reduce the risks. This diagram shows the process of how testing leads to care. And you can see the outcomes of the link to care are medical care and prevention services, both of which are important components of routine testing. Now, the desired outcome of testing can result in important outcomes that will improve quality of life and survival for HIV patients, as well as prevention of new HIV infections in others. It all starts with identification of HIV patients via routine screening and testing. The CDC has revised some of their recommendations for HIV testing. Let's take a look at some of those recommendations. This is a summary of the revised recommendations for HIV testing of adults and adolescents in healthcare settings. Because providers often do not know what the prevalence of undiagnosed HIV infection might be in their patients, all providers are encouraged to initiate screening. In very low prevalence settings, providers are encouraged to initiate HIV screening. If the yield of screening is less than 1 per 1,000, continued screening is not warranted. Oral or written information should include an explanation of HIV infection and the meaning of positive and negative test results. The patient should also be given the opportunity to ask questions and decline testing. Prevention counseling in conjunction with HIV screening in healthcare settings is not required, but it's strongly advised. In April 2013, the U.S. Prevention Services Task Force upgraded from grade C to grade A the recommendation to screen for HIV infection. In adolescents and adults ages 15 to 65, screening should be done, and also those below 15 or over 65 who are at increased risk. In the past, a barrier to HIV testing had been cost. However, in combination with a new recommendation by the U.S. Prevention Services Task Force, in strong support of routine testing and the Affordable Care Act, there will be more coverage provided for HIV testing through various payers, including Medicare, Medicaid, and private insurance. Under the new Affordable Care Act, individuals in the millions will have access to health care coverage opportunities, including HIV testing, through private insurance marketplaces, insurance reforms, and Medicaid. So you can see now there really is no excuse not to test because patients will have the ability to pay for it. It's also crucial to ensure that pregnant women receive HIV testing as part of their prenatal routine screening tests. HIV screening should be included in the routine panel of prenatal tests for all pregnant women. And you can see in the Virgin Islands, there's no opt-out. All pregnant women must be tested. Repeat screening in the third trimester is recommended in certain geographic areas with elevated rates of HIV infection among pregnant women. And the third trimester testing is really important to understand that you only need to repeat the test if the test was negative the first time. The third trimester test is crucial because over 20 cases of HIV infection during pregnancy have been identified via third trimester testing. So it's important to remember that the third trimester testing should be included in the panel if the first test was negative during the first trimester. We are missing HIV diagnoses in all of our practices. Routine HIV testing should be part of the patient care in all types of healthcare settings according to the CDC best practices. While HIV may have a high association with socioeconomic status, it is ultimately a result of behavior that can be represented by many, if not most, of a client's clinic population. And a number of medical and professional organizations support the CDC testing recommendations, including those listed here. And I want to stress that this is not an exclusive list. It's a partial list of all the organizations. There's many more, but these are just some of the more well-known ones. And if you'll notice here, that includes the American College of Emergency Physicians, the American College of Physicians, American Medical Association, among others. The next portion of our discussion will focus on Florida law and HIV testing in clinical practice. HIV testing should be implemented within the framework of existing state and local regulations. As noted, 3 areas of the CDC recommendations often conflict with state laws. These include pretest counseling and risk assessment, the opt-out process, and post-test counseling. Some of these rules are determined based on whether the agency or clinic is classified as a public or private entity. And you'll see at the bottom of the slide, public sector includes Department of Health agencies. Private sector would include things such as hospitals and private practices. Florida has specific requirements for informed consent, counseling, and reporting that impact HIV testing. You can see that informed consent is required prior to testing for HIV, but it may be oral or in writing, and if it's oral, it must be documented in the medical record. Pre- and post-test counseling is not required, but should be available in all healthcare settings if requested, and the counseling can be verbal or in writing, and HIV-positive diagnosis must be reported within 2 weeks to the local health department. Anonymity of testing is a key aspect of Florida statutes. This can make it difficult to follow patients with positive test results and get them into treatment. Also, a second confirmatory HIV test is required before a patient can be diagnosed as having HIV. This statute means that a second corroborating HIV test must be performed to confirm positive. A positive preliminary test may not be characterized to the patient as a diagnosis of HIV infection. A second test must be done in order to confirm positive HIV status. Okay, this slide details the testing related to pregnant women. You can see here that prenatally, testing in pregnancy does include an opt-out process, and a written statement of objection must be placed in the medical records. Testing is recommended during the initial visit, and it should be included in the panel of tests done in the first prenatal visit, and then should be done again within the 28 to 32-week gestation regardless of risk. Women who appear at delivery or within 30 days postpartum with no prenatal care or documented HIV test result after 27 weeks gestation must be tested for HIV, hepatitis B, and syphilis, and a documented test must be listed as either negative or positive. And in terms of women in the ED, if a pregnant woman presents at the ED after 12 weeks gestation with no prenatal care, the ED can refer the patient to the local health department for testing if they don't have the ability to test in the ED. We want all EDs to test, but for whatever reason, they can refer to the local health department for needed testing, and the referral must be in writing. This slide points out components of the consenting and counseling process for HIV testing. Counseling has to include the following points. An HIV test can determine if an individual is infected with the virus which causes AIDS, the potential uses and limitations of the test, the procedures to be followed, and the fact that HIV testing is voluntary and consent to be tested can be withdrawn at any time prior to testing. In the state of Florida, minors may consent to testing and treatment for STDs, including HIV, and the consent of the parent or guardian is not a prerequisite for an examination or treatment. Testing or treatment are confidential. And an important proviso of this is that because testing and treatment of adolescents is confidential, a manner of payment has to be figured out so that the bill does not go to parents. Okay, because if that would violate confidentiality. So they either need to pay up front or figure out some way of billing so that the fact that they had this testing and treatment are maintained confidential. And let's look at the Virgin Islands where there's a real problem with HIV. As we stated earlier when we were discussing pregnancy, in the Virgin Islands, all pregnant women must be tested. And in the Virgin Islands, testing may be done confidentially, but it is not anonymous. So the names of people testing positive for HIV must be reported to the health department. The next section will review the different types of HIV tests that are available. Point of care screening tests. These are tests that are quick and they're easy to do. Some of them are oral, some of them are finger stick, but the key with the point of care is that these are 15 to 20 minute tests, so they give quick results. And here are the different manufacturers and the different tests. Okay, and this shows what some of the different tests look like. You can see OraQuick is oral, some are finger sticks, and some require drawing of blood. Rapid HIV testing, it's good because results are available in less than an hour. A confirmatory test is required. In labor and delivery, it provides immediate information and access to treatment. And there's also multiple FDA-approved tests available. So whoever's doing the testing can choose which products they want to use. And here's a listing of the different point of contact tests, the FDA approval year, and the manufacturer. Okay, the Alere Determine test is a scientifically engineered test for dynamic performance. This test allows rapid screening and support in the detection of HIV, tuberculosis, hepatitis B, and syphilis in just 20 minutes. This point-of-care platform requires minimal training, can be easily stored and transported, and is ideal for any setting. And you can see it's a finger stick, or you can also use whole blood, serum, or plasma. Some of the laboratory-based fourth-generation HIV testing include the Architect and the Bio-Rad systems, both of which the Architect system has 35 minutes for results. The Bio-Rad takes approximately 2 hours. Both must be done in a lab, but they have different ways of being done, and the architect does not distinguish between the detection of P24 antigen HIV-1 or the HI2 antibody. The Biorad can detect early HIV infection. Okay, the major differences between third and fourth generation tests. Fourth generation tests are for use with blood only. It detects the HIV antibodies as well as parts of the actual virus. It reduces the window period of testing to 15 to 17 days, which is reduced from 21 to 24 days, which is the case with third generation, and it will detect most acute infections. Delivering positive results from HIV tests is important and should be done by people trained in communicating this information. As part of this dialogue with the patient, it is important to provide information for follow-up and referral for further treatment and to arrange for the patient to have a confirmatory test. As you will recall from our earlier discussion of Florida statutes, a second confirmatory test is required when using rapid testing to confirm HIV positive results before the patient is confirmed to have HIV. Even with patients with negative results, it's important to counsel patients who have negative results, particularly if they engage in risky behavior or are part of a high-risk group. So think PrEP, pre-exposure prophylaxis. In this section, we will review the signs and symptoms of acute HIV infection. As part of the integration of HIV testing into the practice environment, it is important to know what these signs and symptoms are. Also, it is important to understand that many of these symptoms can also be symptoms of other illnesses, which is why routine testing is so important. Here are some of the common patient complaints that can be consistent with HIV as well as many other things. These diagnoses also are consistent with HIV infections. The next two slides show the frequency of the signs and symptoms of HIV in patients in clinics in Geneva, Switzerland, Seattle, Washington, and Sydney, Australia. You can see that in those three settings, fever was the most common symptom, along with lethargy, myalgias, and rash. So you can see the symptoms of acute HIV infection really are not that much different from the signs and symptoms of many other things, which is why it's really important to test. And then other symptoms and signs include these here, and you can see these as well. Some of the more common behavioral risk factors associated with HIV infections are included on this slide. And it's really important with people in these behavioral risk categories to think PrEP. And again, PrEP means pre-exposure prophylaxis. And that really can help for people in these categories. HIV infection is consistent with all generally accepted criteria that justify screening. HIV infection is a serious health disorder that can be diagnosed prior to the development of symptoms. HIV infection can be identified by reliable, inexpensive, and non-invasive screening tests. Infected patients have years of life to gain if treated early before symptoms develop, and screening costs are reasonable in relation to the anticipated benefits. Among pregnant women, screening has proven significantly more effective than risk-based testing for detecting unsuspected maternal HIV infection and preventing perinatal transmission. Because many of the signs and symptoms of HIV are also common to other conditions, it is important to integrate HIV testing into routine care and consider it in your differential diagnosis. Okay, before we go further, I'd like to pose a question to the audience, and that is, what do you see as barriers to routine HIV testing at your facility? Now, I know you all responded that 100% of you are testing at your facilities, but there are probably still barriers, or there may have been barriers in the past to getting tested implemented. So if you would please type your answers, I would appreciate it, and we'll discuss them at the end. Okay, so we're seeing judgments from the provider about who needs testing and is offered testing, who will pay for treatment, hours of operation are limited, use of translators affects pre- and post-test counseling. Okay, those are 3. Perception of patients about testing are barriers in routine settings. Okay, let's see what else we're getting. Not enough time, takes too long to give positive results. Okay, come on, there's 16 of you on the line at least. Okay, ability to just walk in and get it done. You have to do a lot of paperwork. Who will pay for treatment? Apathy. Okay, hours of operation are limited. Patients don't want to be identified in small communities. Patient resistance. Main barrier is that schools impose their own personal views. Patients not showing up for appointments. Okay, we'll give you a few more minutes. Okay, please write your answers. We need more barriers. And you can write your answer, even if you agree with some of what we've already seen written here, you can still write your answer, even if your answer is the same as someone else's. Money. Okay, I'm going to close this, and I'm going to move on. Okay, at this point now, we're going to review the stages of HIV infection. The first stage is the acute infection. Within 2 to 4 weeks after infection with HIV, you can experience an acute illness, which is often described as the worst flu ever. This is called acute retroviral syndrome, ARS, or primary HIV infection, and it's the body's natural response to the HIV infection. Not everyone develops ARS, however, and it can take up to 3 months for it to appear in some people who do. During this period of infection, large amounts of virus are being produced in your body. The virus uses CD4 cells to replicate and destroys them in the process. Because of this, the CD4 count can fall rapidly. Eventually, your immune response will begin to bring the level of virus in your body back down to a level called a viral set point, which is relatively stable level of virus in your body. At this point, your CD4 count begins to increase, but it may not return to pre-infection levels. Latency. After the acute stage of HIV infection, the disease moves into a stage called clinical latency. This period is sometimes called asymptomatic HIV infection or chronic HIV infection. During this phase, HIV reproduces at very low levels, although it is still active. You may be able to maintain an undetectable viral load and a healthy CD4 cell count without the use of medication during the earlier years of this phase. You may not have symptoms or opportunistic infections. This period can last up to 8 years or longer. Some people progress through this phase faster than others. It is important to remember that you are still able to transmit HIV to others during this phase. Toward the middle and end of this period, your viral load begins to rise and your CD4 cell count begins to drop. As this happens, you may begin to have constitutional symptoms of HIV as the virus levels increase in your body. And at this point, the HIV antibody test will be positive. Okay, during the symptomatic stage, the lymph nodes and lymph tissues will become damaged by years of activity. The disease moves into a stage called clinical latency. This period is sometimes called asymptomatic HIV or chronic HIV. It's possible mutation of HIV virus leading to more pathogenic type. The immune system is unable to keep replacing the CD4 cells that are lost. Initial symptoms are mild but worsen with deterioration of the immune system. And at this point, I'd like to review a little bit about AIDS. AIDS diagnosis is confirmed if a person with HIV develops one or more of a specific number of severe opportunistic infections or cancer. They may also be diagnosed with AIDS if patients have a very low count of T helper cells in their blood. And at this point, the CD4 would be less than 200, or the percentage of less than 14%. Without treatment, they will typically survive about 3 years. With diagnosis of opportunistic infection without treatment, life expectancy falls to about 1 year. It's important to remember that the AIDS diagnosis never goes away even when the patient's condition improves and they no longer meet the criteria. Okay, the next slide, I'm going to stay on for a little bit because it shows the typical course of an HIV-infected individual. So you can see how the ebb and flow of the different lymphocytes, the different blood counts through the phases from the primary infection to the asymptomatic phase on to full-blown AIDS. And if you want this chart, it's available when you download the handouts. Okay, we're now going to summarize what we have discussed earlier in this webinar. With the large number of HIV cases in Florida, Puerto Rico, and the U.S. Virgin Islands, it is imperative that routine HIV testing be part of the care model in all health facilities. Testing is crucial to early diagnosis and treatment and can prevent the spread of HIV, especially among people in groups at high risk for HIV infection. Many people are walking around with HIV and don't even know it until their symptoms develop. It's important to encourage testing and encourage people to know their status. Offering an HIV test to your patients is smart, responsible, simple, and reimbursable. Testing is a preventive service covered through health insurance. And at this point, we are going to address any questions. These are the resources if you want more information. And at this point, we're going to address any questions.
All right, Lynn, thank you very much for a very thoughtful presentation on HIV testing. For all the participants who are with us, please use the speaker questions and technical support issues box, which is to the right of the Q&A slide on your screen right now, and type in any questions or comments that you would like to address, please. So Lynn, let's go back while we're waiting on some questions to come in and talk about some of the barriers that were addressed and any comments or thoughts that you have regarding overcoming these.
Well, I think a lot of them are the same theme: resistance, time, perception. So I think from what I'm seeing of the barriers, a lot of it requires education of providers and even patients. I think patients understanding that there's confidentiality so that their identities will be protected. Money issues need to be addressed. And also, we need to make sure that patients don't feel inhibited or worried that providers will be making lifestyle judgments about them. So I think that's the important thing, is to really emphasize that it's really a best practice to test. We have an epidemic. We have to solve the epidemic, and the way to solve it is to really get everyone involved in testing. I think it's really the right thing to do. So I see a question here. Are patients accepting the routine testing? I think in a lot of cases they are. I think that routine testing, if it's offered, a lot of people want to know, and if it's presented in a way where it's confidential, I think that they're going to be less resistant to it.
And I would agree. You know, people should be aware, and hopefully those in the audience are, the Florida Caribbean AETC does have some resources. Critically important, Health Department has lots of resources that are available in the way of patient brochures, patient posters, things you could put in your waiting rooms that encourage people to understand that HIV testing is a routine part of healthcare. With Florida Caribbean AIDS Education Training Center and a testing project, we've developed some resources for individualized communities so that a provider in a busy emergency room can actually have a card that lists the options and the choices where you can refer a patient if a patient is diagnosed as being HIV positive within your community. We also have need for providers to be aware that our health departments still at present date have resources within the community or resources at the health department to provide that confidential anonymous testing. So if someone has a barrier of acceptance to the testing because of the reporting, as of today there are still areas that you can send your patient where they can have a confidential anonymous test, and the health department is your source to get that referral.
And another barrier, Dr. Beal, that I'd like to also put into that is one of the barriers was listed as use of translators affecting pre- and post-test counseling. And I think as we educate our places that do testing in the area of cultural competency, and we really help translators understand, I think that's really going to help. I think that language barriers are real. I think cultural barriers, cultural stereotypes also are out there. So I think the more education we do of our providers and our professional staff and our clinicians, the more we're going to be able to overcome some of that.
Excellent points. To the comment or question, a question has come in. It needs to be cut and pasted so I could read the whole question, Scott. A question had been raised about the judgmental nature of providers. Any thoughts on how do you address that?
Well, I think that a lot of that, again, has to do with, awareness of other people's beliefs and values. as you mentioned at the beginning, I'm an anthropologist, and so I think that as we train our professional staff about all of the different aspects of culture and language, worldview, and all of those things, I think that it's going to help the providers to understand other people and not make those judgments. And I think how it's framed too. I think if we try not to label people so much as in high risk, or you do this behavior, therefore you should be tested, but make it just as a standard part of our routine panel of health testing, I think that's really going to help.
All right, a difficult question for us in the chat room is, among teens who want to have testing anonymously and don't have the resources to pay for it, what ways or creative ways have you seen to work out payment for such testing? I can certainly state from a health department perspective that your local county health department is going to be a resource to draw upon, and then also the HIV/AIDS and hepatitis section with Marlene Lalota, who provides a lot of money for testing kits. I mean, I would say if there was ever a barrier for testing, to remember that you have HAPCs, who are your HIV/AIDS coordinators within your local regions. You have your local health department, and you have the HIV/AIDS and hepatitis section to draw upon to see if they can be the resource for that test. Certainly there are perinatal programs throughout the state that also have test kits available that they use and can provide for free. Another question, Lynn, was many people are given a lab slip for HIV testing during a routine visit, then do not follow through and go to the lab. Should we offer it during the visit?
That's a tough one. I'm going to defer to you, Dr. Beal, on that with your clinical expertise as a physician. What are your thoughts on that?
I think my first thought is to at least have a dialogue with the patient and find out what is the reason why they did not take the slip to the lab to get the testing. And more than likely, it might be that there is a concern about the lab, going to the lab and having that test on their lab slip. In that instance, offering confidential anonymous testing, as long as we have that ability, is a potential resource, and certainly drawing the test yourself so that they know that you will be handling that and they don't have to go into the lab with the slip could be a very comfortable option.
I agree. I think that's true, and I think that there's a certain stigma, and maybe it's better to embed it in a panel of other tests that patients need to get done. So instead of just marking HIV testing on the lab slip, embed that test in a routine panel of testing.
Very good. We've got time, I think, for one more question that's been sent to us. Cultural competency needs to extend to the person answering the phone, the front desk staff, nurses, translators, checkout personnel, and billing, etc. How can this be done when traditionally practices have a high turnover rate in many of these positions?
Okay, well, I think that that's a very important point. I think that cultural competency training needs to be done as part of orientation to the position, and then I think also staff need to be held accountable from day one. So I think that giving practices the tools, knowing what cultural competency means, knowing how to integrate it into orientation, and holding people accountable on a day-to-day basis and a person-by-person basis, I think is going to help with that. But I think we need a lot of cultural competency training, and we need to understand what cultural competency means and how all of us are responsible for being sensitive and aware of the cultural and linguistic needs of all of our patients as well as our coworkers.